section. So I want you people to participate as much. You can read the prompt there. 76-year-old man presents with bright red rectal bleeding, diabetic. I mean, there are several comorbid factors. He's diabetic, has a mitral valve replacement for which he's on warfarin. He also suffers from angina and has had an MI in the recent past. In view of his comorbidity, a CT colonograph was performed, which is sensible because if there's so many factors there, you wouldn't go straight to a colonoscopy because this showed a 3 centimeter polypoidal filling defect in the proximal transverse colon. He's referred for colonoscopy. How would you proceed?
First of all, he's in recent past MI. I just need to know the duration exactly.
Huh.
3 months old, less than 3 or before 3? Because that's very important.
Yeah.
Because under 3, you don't want to go for it.
Okay, fine. That's good. It's more than 3. Okay.
More than 3.
अच्छा ठीक है चलो. Normally we take 6 weeks as a thing, but it also depends on the merits. So that's a good point. Because if somebody comes in with a recent MI, I usually get called from CCU. Recent MI, they give them TPA, and if the patient presents with hematemesis, so we still do an endoscopy on them. It's a high risk, but okay, you can do it. So it is a relative contraindication, but not an absolute. Okay, that's one point, very good. Achha, theek hai.
Second, we'd like to have a recent ejection fraction of a heart of this patient.
Achha.
MI and anything like just
Achha.
for basic.
Nahi, mother, theek hai, that's a good thing. You can do an echocardiogram, but normally we don't do it.
Is 3 centimeters a large polyp? Is it 3 centimeter?
Is a large polyp, yes.
So it's always suspicious. Even the
Achha, isme hai 3 centimeter polyp.
Yeah. If the ejection fraction was 25%, 30%,
yeah.
I'm not going to stop doing what I'm doing. Is it going to make any difference to what you're doing? That's the point you have to.
With a high sponsor, we should
देखिए बात यह है ना कि what I want to tell you is कि what should be done practically. जी let's concentrate on the points ना. एक तो है कि इसमें polypoidal filling defect है. It is not a polyp. It looks like a polyp, but it's a filling defect. It could be a cancer, right? Okay. So that's one thing. Secondly, जो है ना आप वो चीज़ें करें जो किताबी ना हो जो आप practically करते हैं. तो अगर मेरे unit में ये हो तो I won't be doing a echocardiogram or ejection fraction. We don't do that. Simple as that. We may be backwards, but we don't do that. तो एक तो ये कि अच्छा इसमें main issue जो है that is warfarin है, ठीक है? और क्या है? Diabetic है? हाँ, that's the important thing, ठीक है? तो इसमें mitral valve है, it's a high risk क्योंकि if you stop the warfarin, the valve will cease, ठीक है? Diabetic है, diabetic is not an issue, ठीक है? इसमें आप क्या करेंगे? Well, how would you proceed? जी? वो ज़रूरी नहीं है, आजकल नहीं देते.
And again, because we want to do it again as far as conscious sedation, off sedation, this high sedation would not work. Third thing for the metallic valve, I think the Dr. will have a good point for the metallic valves. Is to prevent endocarditis or something. Maybe
normally, it is not our practice to give antibiotic routinely for this. This is not a current recommendation. नहीं है. हाँ ठीक है हाँ
within the acceptable limits as the patient is high risk we cannot stop his medicine.
Okay.
We have to proceed with
Okay, fine.
right
one way or the other. ठीक है good. What अच्छा ठीक अच्छा ठीक और कोई input? This is how you make multiple choice questions. You ask a question, then you get multiple answers. Some of them are true, some are not true. Normally, what I would do is, you all might disagree with me. I'll stop the warfarin 5 days before the procedure. I'll put him on low molecular weight heparin, which is enoxaparin, ठीक है, तो we'll put them on enoxaparin for 5 days and not give the enoxaparin on the day of the procedure. And check the prothrombin time, just to make sure there's no residual warfarin left in that thing, and I'll proceed with the colonoscopy. Kisa khatam? That's it. Huh? Biopsy you can take, no problems. You can even remove, if you need a polypectomy, you can do that as well. See? Simple.
Even if somebody is on warfarin now,
You can take biopsies on warfarin.
you want to take biopsy, that should not stop.
Yes. If a person is on warfarin and you are only taking biopsies, you can take that. No problems. ठीक है?
Just don't biopsy a gastric varix, that's all.
Thing is it but for CDI and
जी?
stop the warfarin
Yeah.
5 days on the day we miss the enoxaparin and then do the procedure.
हाँ, बस that. Simple और clever stuff नहीं. ठीक है ना? You can do that. Same. नहीं बेटा 5 दिन पहले आपने warfarin stop कर दिया ना. Don't increase your problems. You stop the warfarin, you put them on bridging therapy, इसको bridging therapy कहते हैं. You stop the enoxaparin on the day of the procedure and you carry on with whatever you like to do. Good?
See, you have to look at the main problem that they were first.
Yeah. So, condition for thromboembolic events, ठीक है? High risk are atrial fibrillation, valvular heart disease, not with hypertension. उसमें the risk of causing thromboembolic phenomenon is fairly low. Mechanical heart valve in lateral position is a high risk. Mechanical valve and prior thromboembolic event is any prior thromboembolic event is a high risk. Procoagulable state में जो कोई protein S, protein C deficiency जो भी होती है, within 3 months of DVT-PE, low risk are those conditions.
He comes in high risk category.
ये जान के हाँ, ठीक है? तो ये है, this is the algorithm for it. I don't have to go through all of it. You can read it. सब माशाल्लाह लिखे पढ़े हो.
This hopefully should be in your...
In the thing. Yeah, ठीक. So we'll just discuss the cases. ये ऐसे, this is clever stuff. 21-year-old woman with a 4. जी जी. अच्छा.
USB आपको देगी, उसमें पूरा सब...
Come on, let's go through this, then we can discuss the pros and cons. 21-year-old woman with a 4-year history of intermittent diarrhea, severe lower abdominal pain, is seen in the surgical clinic. On direct questioning, she admits to abdominal distension, rectal dissatisfaction, sensation of incomplete evacuation, and the passage of mucus PR. She is referred for colonoscopy. She is anxious and requests a general anesthetic. How would you proceed? क्या करेंगे?
She's video of tenesmus, right?
हाँ जी.
Rectal dissatisfaction and mucus discharge PR.
Yeah.
Right? So this is, the complaints are not unwritten, and we need to entertain these complaints. So I think, and say load. Yeah, why not?
इसमें question में ये क्या उसमें
नहीं देखें वो नहीं आप देखें आप क्वेश्चन पढ़ा करें. She is referred for colonoscopy. She is anxious and requests a general
How
anesthetic.
would you proceed is the question.
Colonoscopy under GA करना चाहती है. How would you do it? Under GA करेंगे कि under KINS?
Anxious patient, young
हाँ.
patient requested, why not?
अच्छा
counselor
First of all,
अच्छा
counseling.
अच्छा जी. आप क्या करेंगे जी? एक करके सर. हाँ एक हाँ बताएं.
counselor and paper options.
अच्छा जी. कैसे?
First one being to explain her the risks and benefits
हाँ.
of both the GA and without the GA.
अच्छा good.
Secondly, if she still says that I want to be knocked out,
अच्छा.
then we give her options further on. This include painkillers and conscious sedation
अच्छा
and we go to
ठीक है.
general
Okay,
anesthesia.
that's good. I get the point. हाँ ठीक है. अच्छा ठीक है. आप बताइए जी क्या करेंगे?
Risk and...
अच्छा अच्छा इसमें देखिए 2 पॉइंट्स हैं. एक तो देखिए ये सर्जिकल क्लिनिक है. नो डिसरिस्पेक्ट टू सर्जन्स. ठीक
I
है.
was just going to ask you, does she need a colonoscopy? No.
The thing is, does she need a colonoscopy? I would never do a colonoscopy in her.
We were just discussing this, you were not here. I was
This
saying the
is-
same thing.
you-
Why would you do lower?
If you want to counsel her, tell her, look, madam, you do not require a colonoscopy. Colonoscopy is not the answer to your problem. You require treatment with diet, therapy, lifestyle changes, this, that, right? It's irritable bowel syndrome.
IBS.
And she's only 21. There's no blood PR, nothing. The other differential diagnosis would be inflammatory bowel disease. अगर आप चाहें तो you can either do a rigid sigmoidoscopy or you can send off a stool sample for fecal colprotectin. which is an inflammatory marker in stools, and it's a good screening tool. So this girl, subjecting her to a colonoscopy under a GA is two high-risk procedures where they are not needed. ठीक है? So that is the point I wanted to press home. Okay, 58-year-old lady.
If I can just put the point you made is very important. The fact that somebody is referred to you for a colonoscopy does not mean that they should get a colonoscopy. You're an expert. You should let us see first whether they need a colonoscopy. Otherwise, you don't need a colonoscopy.
Exactly. I mean
That is a very, very good point and very relevant to our system and practice.
एक और जो चीज़ मैं अपने ट्रेनिंग्स को भी कहता हूँ, हर एक को कहता हूँ, gastroenterology, cardiology, they are procedural specialty. Whenever we get training, they are obsessed about when am I going to do, or how many endoscopies am I going to do, or how many catheters am I going to do, or angios am I going to do. It is equally important to get yourself skilled in assessing patients as much as you need to perform procedures. Because the important thing is whether this patient requires a procedure or not. Because there's nothing worse than doing an unnecessary procedure and ending up with a complication which can be terrible. So that is most important. Let me get this. Okay. So 58-year-old lady who is seen in clinic with a 5 kilogram weight loss, abdominal pain and recent onset constipation. ठीक है जी? 5 kg weight loss, which is significant. Abdominal pain, recent change in bowel habit basically. This is what you would term, right? She has a history of stage 4 chronic kidney disease, CKD4. She is referred for colonoscopy. How would you proceed?
Sedation will come in.
ESRD with dialysis, without dialysis.
Dialysis thing है, लेकिन she is CKD4. She's got significant renal impairment.
Okay.
But she's not on dialysis.
No, she's not on dialysis. वरना फिर लिखा था ना, देखिए आप. हाँ.
So that means history is very significant.
जी?
Colonoscopy is required.
Is required, ठीक है. We agree on that, okay? But how would you do it? She's got kidney disease, so इसमें क्या significant portion है?
First of all, the bowel prep.
Bowel prep, that's it,
The
right?
potassium
Phosphorated containing
हाँ, that's a, तो इसमें you have to be careful about the bowel prep you give. Normally हमारे यूनिट में हम देते हैं सबको movie prep. हमारा movie prep या clean prep, पिकोलेक्स हम नहीं देते unless patient specifically ask for it या कोई indication हो. लेकिन यहाँ पे ये पिकोलेक्स देते हैं. So in that case, you have to give them a different type of bowel prep. या मेरे ख्याल में move call है कि movie call है वो है. हम उसका best उसका जो हम लोग clean prep होता है that's the industrial dose of movie call basically. ठीक है तो आपको उस किस्म का लेना होगा.
Because अगर वो है तो undercover nephrologist, because we need to give him outfit somehow.
हाँ.
So we should have to stabilize the renal function. The
But
loss
the-
of water,
normally
balance the.
In our unit, we do not get help from nephrologist routinely. ठीक है? This is the problem, so we give them a different type of bowel prep. लेकिन you have to be conscious of the fact कि इसमें hyperphosphatemia, hyponatremia, hyperkalemia के problem हो सकते हैं ना. ठीक है? तो अगर आप हाँ, if you got the luxury of having a nephrologist and you want to consult, ठीक है, that is good practice. लेकिन it is a question of bowel prep. ठीक है? So that's what I want to highlight. जी? हाँ, इन पेशेंट में फिर वो दैट इज हम लोग रूटीनली हर एक को वो ही देते हैं, लेकिन चूंकि वो एक्सपेंसिव होता है तो अक्सर यूनिट में पिकोलेक्स देते हैं, लेकिन हाँ जी. असल में चक्कर ये होता है कि आप स्पीड जब देंगे ना तो वो भी देंगे तो इट्स अ लार्ज फ्लूइड लोड फॉर दैट टू हैंडल वो ना इसमें ये कि आप यू हैव टू बी कॉन्शियस ऑफ द फ्लूइड ओवरलोड as well as the electrolyte imbalance. ठीक?
In this case, yes, we can proceed because floppy is like relative contraindication right now. It is according to guidelines. It's not absolute. And these is a series program.
नहीं इसमें जो है ना
इसमें क्लॉपिंग डॉक्टर को स्टॉप करना है एस्पिरिन.
हाँ हाँ दैट्स क्योंकि दूसरा इसमें दूसरी बात ये है कि यू कैन डू colonoscopy with clopidogrel diagnostic. You can't do therapeutic procedures there. बाद लोग बायोप्सी भी नहीं लेंगे, लेकिन हाँ यू कैन स्टॉप क्लोपिडोग्रेल एंड यू कैन पुट देम ऑन
So
एस्पिरिन.
then he will be on aspirin. जो कॉपी पे होगा वो aspirin में भी होता है.
Not required.
I mean,
Not
but there is no
necessary.
stands. Recent 5 years ago, 6 months तक तो aspirin वैसे मिलती है उनको.
3 months हो गया. 3 months from now. That's
ये है, ये जो है असल में दिस इज वो है, ठीक है, लो रिस्क हाई रिस्क. हाँ इसमें कुछ नहीं करना आपको, इसमें यू डोंट नीड टू डू एनीथिंग, क्योंकि बायोप्सीज वगैरह में आप कुछ नहीं करते हैं, ठीक है. ये आपके उसमें होगा. 82-year-old lady undergoes colonoscopy for iron deficiency anemia. In view of her age and frailty, she was admitted for bowel prep. The procedure is prolonged and difficult because of severe diverticity and very poor bowel cleansing. A 5 mm polyp is removed from the transverse colon by heart biopsy. You are called to the recovery area because she is complaining of severe generalized abdominal pain. How do you proceed?
Assess करेंगे कि abdomen basically a surgical abdomen or not.
जी
Is diverticular? नहीं, colon है, diverticular disease है. We have done a scope. She is a high risk for perforation of the
बिल्कुल.
dural areas, ADD.
ठीक है.
So the clinical examination is the first thing. 67 pattern is not, and you can adjunct with the ancillary imaging like X-ray, neoperitoneum, and
बिल्कुल
then you
ठीक.
complement according to that is yes, then you go for the
It's advantageous to have a surgeon on board.
There's a very interesting thing there.
इसमें एक और छुपी हुई बात है.
Diverticular disease.
वो तो ठीक है, आपने सही बातें की है.
Does not really increase the risk of
Bowel cleaning भी है तो septic level भी high है.
You use hot biopsy post in
हाँ.
transverse colon.
yes.
Hot biopsy,
You should.
hot biopsies, hot biopsy forceps have been removed from our department completely. Completely. इसमें अगर आपको बहुत शौक है पॉलिप रिमूव, और तो I wouldn't remove a 5 mm polyp in a 82-year-old lady. By the time it becomes cancer, it will be 12 years or 14 years. उससे पहले ये क्या हो
Or you
जाएगा?
could do it with a cold stain. 5 mm polyp, you don't.
You
need
do a
to
cold
use
stain.
diathermy.
हाँ.
Just take it out with a cold stain.
So the hidden question is the hot biopsy forceps. Diverticular disease में you shouldn't perforate anyway.
Right, that's what I was saying. I don't place that.
मतलब
Hopefully not.
you shouldn't. तो इसमें सिर्फ the message home is hot biopsy forceps. Never ever use a hot biopsy forceps for polypectomy.
Chances in right colon, whatever.
You can use it in the rectosigmoid.
हाँ.
There's no problem because
Yeah.
it's much thicker. But once you go beyond, as you go more proximally, the colon becomes thinner and thinner, and you don't want to take it.
Right colon is 1.5 millimeters thick or thin, and left colon is 3 millimeters thick, wall channel. So, especially when you are doing a colonoscopy and you distend it there, it gets stretched and it is less thinner. Yes,
Absolutely.
it's
And
more
if you
thinner.
want to
Yes.
see that,
Yeah.
you know, really, when you do a colonoscopy on table with your surgeons, I mean, whenever I've done
Oh, yes, it's frightening.
small bowel, I enter the small bowel, I'm looking very, you know, normally you only look inside, you see from inside, so you're not bothered because you see the mucosa. And you actually look at it from outside and oh, this is good.
If you see anyone, Saad, if you see anyone doing APC on table colonoscopy, you actually see the steam and the smoke coming out on the peritoneal side. All right. 47-year-old man underwent colonoscopy and snare polypectomy. 18 mm sessile lesion from transverse colon was for 18 mm sessile polyp, right? Like an EMR. There was some bleeding at the time of polypectomy controlled by placement of endoscopic clips. His wife telephoned the endoscopy unit 3 days later to say that he is experiencing a great deal of abdominal pain. You are asked to advise. What do you do? हाँ, अच्छा और anything else? उसको टकोर दें, दम डालें, हाँ नहीं, हाँ, come to ER.
At your stage, you should be saying, I'm concerned about perforation,
Yes.
so I need to evaluate. Rather than, like medical students, you start jumping to, I'm going to do this. At our stage now, and you're part of us, Say what are you worried about? You're worried about this.
Yes, exactly. So come to ER, definite.
Come
ठीक?
to ER, evaluate for perforation
Yeah.
and period.
ठीक है? क्योंकि चक्कर ये है, whenever you are suspecting a complication, it might be just, but it's 3 days later, it is significant, it could be a perforation, a delayed burn, see?
And again, if you look at the question, there is always a clue in it.
Yeah.
It's a sessile 1.8 centimeter polyp.
It's quite a big
So
region.
and it's in the transverse colon again. So
Thin.
somebody has done diathermy
And
in the
it's burns
transverse
through.
colon. So you think about perforation.
Yeah. So उसमें always play safe. अगर ये ठीक भी हो तो आप, it's still better to bring him to the ER.
Don't ignore your patient is the message from here. The fact that you did a very good polypectomy does not mean that somebody complains. You say, no, it's not because of me, go somewhere else.
Yeah. Discuss the safety of in pregnancy cardiac pacemaker implanted. ठीक? ये just to pick up the points. Pregnancy में you avoid colonoscopy if you can, unless it is absolutely necessary, but you can do it. Cardiac pacemaker, again, if it is one with a defibrillator, then you have to ask them to put a magnet on it. अगर आप diathermy करनी है, तो उसको वो करें, क्योंकि वो fire ना करे उसके साथ ना.
Basically, in ERCP, what we do
Huh.
here is, when I have a patient with permanent pacemaker, I tell the cardiologist
To comment.
they send their text, they take care of whatever they have to do. I don't even want to know what they do.
I only know that they put a magnet on
I
it.
know that they do something.
They do
As long as
something.
they take that, but I'm okay to do my job. Nothing.
With an implanted cardiac defibrillator, that is the one which they take magnet on it. Cardiac pacemaker का इतना नहीं होता, but we still ask the ECG techs to come and help, right? And colitis में ये है कि it's contraindicated. Acute diverticulitis में it is relative contraindication as well. ठीक?
Probably
Chale, I think
call it a day.
we'll call it a day.
We need
I
to
think,
see.
yeah. Okay, fine. That's
We
good.
need a slide of reporting.
मैं उधर आता हूँ.
I was irritated. The side of looking at going up like a balloon, right?